Thank you very much. Thank you very much. My name is Emnet Tesfaye. I am a physician specializing in emergency medicine and critical care. I will be speaking on the burden of unintentional injury and trauma system development in low and middle income countries. My presentation doesn't violate any properties of any other person or entity. And also I refrain from using names, photographs, or other patient identifiers in educational presentation materials without the patient's knowledge and written authorization. The outline of my presentation will cover introduction, burden of unintentional injury, current trauma system, barriers to trauma care, and a way forward. So most of trauma diseases occur in low and middle income countries, affecting productive age groups. Also, 1/3 of mortality can be prevented by improving the healthcare system. There is a limited evidence on public health impact of problems from injuries and the actual burden of injury. As you can see in the picture, trauma accounts for 10% of the world's deaths, which is more than 1.5 times that from fatalities resulted from malaria, tuberculosis, and HIV combined. When we talk about the burden of injuries, we are referring the morbidity, mortality, disability adjusted life years, and impact assessment. According to the World Health Organization, injury kills about 5.8 million people each year, and this mortality and morbidity of trauma disproportionately falls in low-income countries, where over 90% of injuries occur. With trauma fatality rates in low-income countries are nearly triple those in high-income countries. People with life-threatening but survivable injuries are 6 times more likely to die in this setting, which means 36%, than in high-income setting, which means 6%. Also, trauma accounts for more than half of daily emergency visits in major health facilities, and interpersonal violence as well as road traffic accidents are the 2 commonest types of injuries. Despite the lack of systematic approach for trauma care, all hospitals give trauma service. Additionally, for every injury-related disease, it is estimated that 10 to 30 people survive with some form of permanent disabilities. And overall, if trauma fatalities in low-income setting could be reduced to the rates of high-income setting, it's estimated that 1.7 to 1.9 million lives could be saved annually. In Africa, solely 38 per 1,000 disability-adjusted life years are reported, compared with the global figure of 27 per 1,000 deaths. As you can see in the picture, the total number of deaths in 2017 were 41,834. From the observed annual deaths, 65% were from road traffic injuries, interpersonal violence, self-harm, and falling down accidents. This figure also showed the number of deaths resulting from injuries among males was more than 2 times higher than females. And this difference was consistent with the age standardized rate and throughout the 28-year mortality trend observed, which means from 2008 up to 2017. More than half of, which means 52% of all deaths due to injuries have occurred among age under 35. and the number of diseases is highest among age under 5, as well as age from 15 to 24 years. More stratification of the number of diseases by injury types in 2007 and 2017 has indicated a consistently higher number of diseases among males, though this difference was not seen in children under 5. The other picture revealed the age standardized ratio of disability adjusted life years in East African countries, especially in Ethiopia, has declined between 1990 and 2017. It was peaked in 1998 and 2001. After that, it showed a gradual reduction. The trend of DALYs in Kenya and Uganda seems to be consistent across the years. In comparison, the magnitude of DALYs observed in Ethiopia was higher than that observed in Kenya, Tanzania, Uganda, and Zambia in 2009. Afterwards, it has become consistent with these countries except Tanzania. The DALYs and deaths stratified by types of injuries and by gender among these East African countries is consistently higher for males than females. So there are ongoing efforts to curb this trauma burden in these countries. For example, in collaboration with the World Health Organization, in order to mitigate the significant health burden caused by trauma and the associated injuries. Beginning in 2004, the WHO released a series of documents aimed at improving the system of care for trauma patients. One of these documents were the guidelines for essential trauma care, which is identified as ongoing trauma education as one of the most important aspects of trauma system development in these settings. But despite all the efforts, recent studies showed that few countries had implemented policy changes at national level based on these documents. To further strengthen trauma essential care service, the World Health Organization released a resolution in its meeting in 2015, which is called Strengthening Emergency and Essential Surgical Care and Anesthesia as a Component of Universal Health Coverage, which addresses the public health gaps arising from lack of safe, affordable, and accessible surgical and anesthesia services. Apart from this, in 2019, the World Health Assembly Resolution 72.16 encouraged WHO member states to promote emergency care as a key component of universal health coverage and integration of emergency medical service systems and emergencies into overall universal health coverage strategies. Current efforts to improve trauma health system includes trauma evaluation and management courses, as well as advanced trauma life support courses are being given in few countries. There are also few setups which are establishing pre-hospital care system. Other countries are developing a curriculum and expand education to be inclusive of paramedics, emergency physicians, intensive care physicians, and general surgical professionals. Also, few countries are strengthening their disaster preparedness and response systems. There are also ongoing quality improvement projects. Barriers to give this trauma care can be categorized into 3 delay systems. The first delay is due to wrong perception of the community to EMS system and poor community awareness to seek medical attention after injury. And the second system is reliance of giving service for trauma victims due to poor infrastructure, like lack of adequate water supply, electricity, space, services, and poor referral system. Finally, the third delay is due to lack of standard of care procedure and also poor registry system, inadequate manpower, limited resources, and financial limitation. There are continued challenges, including educational gap. Trauma training is not integrated with most of undergraduate or postgraduate curriculums, and injury severity index is not implemented in most hospitals. There is also limited adoption and dissemination of trauma guidelines. Critical care training and service has only been recently given in big hospitals, and lack of refresher trainings can be few reasons for continued challenges. There is also a system gap, which includes lack of organized pre-hospital care system and workforce. In most of the facilities, there is no nationally organized dispatch center and emergency free toll number. Data keeping habit and monitoring is poor in general. Also, there is poor practice of applying or using WHO trauma registry system. So the next step in trauma education improvement is countries should disseminate the trauma guideline nationwide and should create appropriate protocol and system. There should be adequate number of educators and instructors in order to teach medical students as well as all health professionals in giving care for trauma patients. There should be standardized trainings like advanced trauma life support should be implemented in all major trauma centers. And also there should be integration of other health science faculties into the trauma ecosystem, like inclusion of psychiatrists, psychologists, rehabilitation professionals, and public health professionals. As a way forward, there is an inherent lack of road traffic injury surveillance system in most of low and middle income countries. So governments need to focus on establishing legislation and provision of adequate policies in giving service which provide accountability when laws are broken. And also clinical governance strategies such as quality improvement and auditing are valuable tools which satisfy stakeholders and must be encouraged in this facilities healthcare system. These are my references. Thank you for your time. Thank you.